Okay, let's spend the rest of our time looking at the autonomic nervous system and the specific receptors that we'll commonly see in practice with agonists or antagonists of those receptors. If we think about what you might remember from the difference between the nervous system and the endocrine system, if you think about if you happen to be the first person who was awake in your household, and you take a shower in the morning, you go in the bathroom, you turn the light on. When you turn the light on, immediately the light comes on right away. If you go to turn the water on, and depending on where your hot water heater is, it might be seconds to a minute or two before the water is hot uh, in the in the shower. And the difference here is how quickly the electrical conduction system produced the effect of the light on versus it took a little bit of a while for the hot water to get through the plumbing system. When we want to innervate organs, we can innervate them primarily through the nervous system, electrical, and that's pretty rapid. But we can also secrete hormones like epinephrine via the adrenal gland through the plumbing, through the circulatory system, which would produce a slight delay in the onset of that response compared to innovating through the nervous system. So most of what we're going to focus on is innovating through the nervous system, not as much the endocrine system. Sort of differentiating those principles yet again here in this slide sort of explains what we more or less just referred to, but the endocrine system being transmission via a chemical blood-borne hormones versus the nervous system relying on rapid electrical transmission. When we think about the nervous system, you may remember this from basic anatomy and physiology. We differentiate the central nervous system from the peripheral nervous system. And we're not going to focus too much on the central nervous system today. That's the brain and the spinal cord and things that happen within the cerebral spinal fluid. Our focus today is going to be more in the peripheral nervous system, all of the nervous tissue outside of the central nervous system. These are broken into the somatic and the autonomic nervous systems. The somatic nervous system, really, we think of voluntary motor control. The autonomic nervous system are all those automatic functions that are involuntary. And sometimes those merge. If you, for example, take a moment and just swallow now, the initiation of the swallow and down the peristalsis that starts in your swallow in the upper esophagus is somatic. It's voluntary. It's controlled. But it transfers into the autonomic nervous system where there is not a voluntary control of that function, and that's the autonomic nervous system we're going to focus on. The subgroups of that autonomic nervous system are the sympathetic and the parasympathetic systems. You may have learned the sympathetic system is the fight or flight system, and the parasympathetic as feed and or breed or sometimes rest and digest. And these two systems innovate a lot of involuntary organ systems. Sometimes they each innovate the same organ, sometimes they're a little different. We'll walk through some of that. We also want to differentiate afferent from efferent systems. Afferent systems are the nervous system that transmits information, sensory information, from anywhere in the body back up to the central nervous system. So the central nervous system then can initiate some reflex or some other thing. For example, the baroreceptors affect stretch in the aortic arch or in the carotids that signal to the body if blood pressure is too high or too low. So an example of that baroreceptor reflex arc is that the stretch in the aortic arch senses a drop in blood pressure that sends a signal to the brain. And then the reflex response are the efferent nerve fibers that will innervate the heart to increase heart rate or the blood vessels to cause vasoconstriction, ultimately to increase blood pressure. We're going to focus on these reflex response, these efferent fibers that carry messages from the brain back down to the body. In these efferent systems sending messages, we divide those pretty much into the autonomic and the somatic, the skeletal muscle tissue. And from the automatic, we break those down, those involuntary efferent systems to the sympathetic and the parasympathetic. So we have a chart here in a couple of slides that will kind of explain that, but we're going to first go to a glossary slide. I want you to sort of pay attention to this slide and come back to it when our nomenclature gets confusing, as it will. There are lots of terms, unfortunately, for the same thing. So we're going to be talking about the autonomic nervous system and specifically the sympathetic versus the parasympathetic system. And we're going to refer to drugs that are either agonists or antagonists. And you'll find multiple terms can refer to the same thing. And when you get confused about that terminology, come to this slide. So whenever we see a drug that mimics a drug that mimics a physiologic action, works as an agonist, that might be called a whatever mimetic. A sympathomimetic is a sympathetic nervous system agonist. You also might find a drug that's referred to as a lytic. A lytic drug blocks action, or that would be an antagonist. So a sympatholytic drug would be a drug that blocks something in the sympathetic nervous system. You may also hear the terms cholinergic versus adrenergic. Cholinergic involving acetylcholine. Most often, we consider cholinergic as a subset of receptors we'll talk about in a minute. But we usually consider cholinergic referring to the parasympathetic function because that's acetylcholine is the neurotransmitter at the end effector organ of the parasympathetic system. And you might also hear the term adrenergic referring to adrenaline, which is epinephrine, or norepinephrine is a very similar compound. And that would be sympathetic or adrenergic are sort of interchangeable terms. Okay, so when we see the terms adrenergic or sympathetic, or you hear the word parasympathetic or cholinergic sort of used interchangeably, there's sort of some of those are sloppy terms, but you'll kind of hear them sort of mixed in. Perhaps I'll use them, but you'll hear them in other places as well. Okay, this slide probably reflects almost everything in a broad terms you'd want to know. And I'm going to start with looking at this slide for a couple of minutes, and then we're going to move on to more detail. Okay, so when we look at this slide, we're looking sort of all of the efferent fibers. These lines, the 4 lines vertically going down from the on the autonomic side, the 3 to the left, and the somatic on the right, are all efferent, representing efferent nerve fibers from the brain down to tissue in the body. Let's start on the right-hand side first, the somatic nervous system. We'll talk about this for a minute and then leave it alone. When the brain sends a signal to voluntary skeletal muscle, striated muscle, it sends one long signal with no break, one long nerve fiber, no ganglia, no break in there. Ultimately, at the neuromuscular junction in that muscle fiber, the neurotransmitter that's released is acetylcholine. And acetylcholine binds to a nicotinic receptor. It's called a nicotinic receptor because it also has an affinity for a substance called nicotine. So when we give a drug that blocks that specific nicotinic receptor, you can have muscle paralysis. Muscles won't twitch, they won't move. And we can give a nicotinic receptor blocking drug called a neuromuscular blocker that is very specific for the subset type of nicotinic receptor at the end of the somatic nervous system skeletal muscle. We might want to use those medicines when a patient is going into surgery and you don't want the patient to twitch during neurosurgery. We sometimes use it in the ICU, in the intensive care unit, when a patient's on a ventilator and has a lot of muscle movement around that. But whenever we use this neuromuscular blocker at this subset of nicotinic receptors in striated muscle, we absolutely have to have an airway in place for this patient. We have to have the patient sedated. We'll talk much more about these drugs later in the year, but they're drugs we have to be very careful about how we use them, and we need to sedate patients and have airways in place before we start using them. We'll talk more about those in surgery and intensive care unit much later in the year, but we won't sort of revisit that for a while. The remaining on this slide is the autonomic nervous system. Let's speak just briefly on the left and sort of get that kind of out of the way of our discussion too. The sympathetic nervous system can, in addition to directly sending nerve fibers right to the tissues or end organs it's going to do, it can also send a signal to the adrenal gland to secrete epinephrine in a fight or flight circumstance. And the epinephrine will bind to receptors throughout the body to produce similar to a sympathetic response. That's another way to innovate things. And when we give a drug, it sort of mimics that effect by delivering the drug through the blood instead of the hormone like epinephrine. But where we really want to focus are in the middle two columns here. The sympathetic nervous system sends all of these signals throughout the body from the brain to ultimately to multiple organs. Sympathetic nervous system innervates, has a set of fibers that go to the heart, has a set of fibers that go to the bronchioles, have a set of fibers that go to the bladder, that go to other areas of the body. And very similarly, the parasympathetic system has sets of fibers that innervate many of those same systems and sometimes different systems as well. Each of those nerve fibers, depending on where they end up and where they innervate, produce different physiologic things depending on what the effector organs are. So on the sympathetic side, we're going to focus on, at the very bottom, the adrenergic receptor, where the ultimate neurotransmitter is norepinephrine. That is an adrenergic receptor. But the shape of that adrenergic receptor is a little different in the heart than it is in the bronchioles, than it is in the blood vessels, than it might be in other places in the body. So we'll have subsets of adrenergic receptors, and we'll talk about these in a bit. Alpha 1, alpha 2, beta 1, beta 2 are the four most common in the adrenergic side, and it depends on where the location is. Okay. Before the nerve stimulus gets ultimately to that end organ, be it the heart, the bronchioles, wherever it is in the sympathetic side, it first sends almost like a extension cord plug connection. It sends the message through one synapse in the ganglion where acetylcholine is released to a nicotinic receptor, which then continues the signal on down to the adrenergic receptor. We have a similar thing going on in the parasympathetic side, where acetylcholine is released at the ganglion to send the parasympathetic signal down to ultimately its end effector organ, which again might be the heart, the bronchioles, the bladder, somewhere else. And that also involves acetylcholine at a nicotinic receptor, ultimately sending the signal down to its effector organs, which again is acetylcholine at a different receptor called a muscarinic receptor. Gets a little confusing because here is the same neurotransmitter, acetylcholine. It's involved in all of these nicotinic receptors, some on the somatic side, some in the ganglion, and also these muscarinic receptors at the end effector organs. So acetylcholine binds to lots of things. The muscarinic receptor, though, which binds, it's called that because it binds to a substance called muscarine, is chemically structured similar enough to the nicotinic receptors that acetylcholine will bind to it, but different enough that we could have a drug that's specific for the muscarinic receptor and doesn't bother the nicotinic receptors at all. Similarly, the nicotinic receptors in striated muscle are subtly, just chemically, a little different in their configuration than the nicotinic receptors in the ganglionic, in the level of the ganglion halfway up down the spinal cord. And so we can have drugs that might work on the somatic nervous side of the nicotinic receptors there, but they wouldn't have much effect on the level of the ganglion. That's a pretty common scenario. So it's unfortunate that the nicotinic receptors in the ganglion have the same name as the nicotinic receptors in the somatic side because chemically there are subsets of those receptors. Okay? So this is one slide. We spent a lot of time on this graphic, but you may want to watch this a second or third time, this one slide, watch this again, kind of get a sense of it, and then kind of keep moving on. Okay, what we're looking at is we're going to really focus on the sympathetic fibers that go down to, a set of fibers that go to the heart, ultimately to the effector organ, the adrenergic receptor in the heart, where norepinephrine gets released. And the parasympathetic side might also have a set of separate nerve fibers that go to the heart and release acetylcholine to bind to a muscarinic receptor. If I give an agonist on the adrenergic sympathetic side, or I give norepinephrine there as an agonist, I expect heart rate to go up. If I give acetylcholine on the muscarinic receptor on the parasympathetic side, I expect heart rate to go down. Similarly, if I stimulate the sympathetic nervous system at the bronchioles, that's called a beta 2 adrenergic receptor, I'm going to have bronchodilation. If I stimulate the muscarinic receptors in the bronchioles, I might have bronchoconstriction. But if I had an asthma patient in the emergency department, I could either give them an agonist at the adrenergic beta 2 receptors, opening up the airway, or I could give them an antagonist at the muscarinic receptors in the bronchioles, also opening up the airway. And lo and behold, there are two such drugs. We do exactly that. We give inhaled albuterol, which is an adrenergic beta 2 agonist at the bronchioles on the sympathetic side to open the airway. And we give an antimuscarinic drug and muscarinic blocking drug inhaled called ipratropium on the parasympathetic side also to open up or relax the airway. And so what are we doing? We're innovating both the sympathetic and the parasympathetic systems using an agonist on the sympathetic side and an antagonist on the parasympathetic side, lo and behold, to produce a physiologic response of opening up someone's airway. Very common. That combination product of albuterol and ipratropium is also called duoneb, and we give that by nebulization. It's two drugs, duo, given by nebulization, neb, to open up an airway for patients who have asthma or significant COPD, bronchitis, where their bronchioles are more constricted. All right, so the rest of what we've got is a little more detailed here. The autonomic nervous system, we classically think of broken down the sympathetic system, the fight or flight, and the parasympathetic, the rest or digest. I kind of think of an agonist on the sympathetic side most often as almost like you're putting your foot on the gas pedal. And the parasympathetic side, for most of the time, it's like putting your foot on the brake. Okay, it's not always that case, but it's often that case. And we can give agonists or antagonists at either these receptors or subsets of these receptors to make something happen in the autonomic nervous system and ultimately the tissue level to innervate a biologic response. So when we think of the sympathetic system, more often we're thinking of the end effector organ where norepinephrine or noradrenaline is the classic neurotransmitter, and we can give a drug that works at the place where norepinephrine works in the sympathetic system, at the end effector organ at the heart, at the bronchioles and the lungs, in the blood vessels. We'll talk about those specifics that happen at each of those location sites. Or we can innervate the parasympathetic system where the neurotransmitter is acetylcholine. Thus, you'll often hear the term cholinergic for the parasympathetic side because acetylcholine is the neurotransmitter at the end effector organ. We've already talked about fight or flight for the sympathetic or parasympathetic rest, digest, or feed or breed. And we often see that many organs are dually innervated by both of these systems, one gas pedal, one brake. As we look at the nature of this neurotransmission, we have the preganglionic neurons we alluded to, where ultimately acetylcholine is released in the level of the ganglion, and ultimately the postganglionic nerve fibers in each of these systems, and there are multiple in each of these columns, depending on where their fibers are going to, which organs, which ultimately release norepinephrine at the adrenal side and the sympathetic side, or acetylcholine at a muscarinic receptor on the parasympathetic side. We don't really give drugs that work at the level of the ganglion. We did decades ago, but they are very non-precise kind of drugs, and so we don't really innovate those. What we do have drugs that work, though, are at the end effector organs on the sympathetic side or on the parasympathetic side, down at the level of the heart, the bronchioles, again, blood vessels, and the like. So I don't think we need to focus too much on the preganglionic fibers, really focus on the postganglionic fibers. And again, because I'm the pharmacist, I have to show you a chemical structure. Here's a chemical structure on the left of acetylcholine and on the right of norepinephrine. Norepinephrine's chemical structure actually looks a lot like epinephrine and pretty similar to a third chemical substance called dopamine. These three neurotransmitters we'll show again in a little bit, but those are primarily involved on the adrenergic side, on the sympathetic side, whereas acetylcholine we think of as the end effector neurotransmitter on the parasympathetic side. I'm going to have a number of these kinds of tables, and I'm going to have you focus on things a bit more in a bit. But as an introduction here, let's kind of spend a couple of minutes on this table. Let's look at some of the common organ systems that may be innervated by these nerve fibers, these efferent fibers, either on the sympathetic side or the parasympathetic side. We have the heart innervated, the bronchioles innervated in the lungs, and blood vessels, systemic blood vessels, the fourth one down, innervated primarily by the sympathetic nervous system. So if I give an agonist in the sympathetic nervous system, that is an agonist that binds to those sympathetic fibers in the heart, those receptors in the heart. As an agonist, I would expect increased heart rate and the force of contraction. If, on the other hand, I gave a parasympathetic agonist at the level of the heart, I would expect the opposite to happen. At the level of the lungs, I give an agonist in the sympathetic side, I expect bronchodilation. That's albuterol. If I gave an agonist on the parasympathetic side and the level of the bronchioles, I'd actually have bronchoconstriction. And actually, there is a drug we sometimes will use in pulmonary testing that is used for that called muscarine. Methylcholine. And methylcholine is sometimes used as a pulmonary challenge to see the degree to which a patient might have sensitivity in their parasympathetic system to this stimulation. But most often in clinical practice, we'd give an antagonist at the level of the bronchioles for opening up an airway, because usually therapeutically our goal is not to close the airway. Okay? The third one on this table is lots of other things. I just want you to kind of not focus on the other things that are going on in this table. But the third one is the blood vessels. And the blood vessels are innervated by both alpha and beta receptors. And we'll talk a bit about those more, but mostly the alpha receptors, where if we give a stimulating drug at alpha 1 receptors, we'll talk more about this in a bit, I'm going to expect vasoconstriction. So epinephrine, as a classic sympathetic agonist, is going to increase heart rate, it's going to dilate the bronchioles, and it's going to constrict blood vessels as the predominant effects of epinephrine, because it's going to bind at all three of those receptors, subsets of receptors on the sympathetic side in the heart, the bronchioles, and in blood vessels. All right, let's talk about acetylcholine. Acetylcholine, the neurotransmitter, both at the level of the ganglion and also at the end effector organs and the parasympathetic side. Basically, acetylcholine as the neurotransmitter gets released. So let's walk through what that looks like. Let's say this is the level of the ganglion. Acetylcholine gets released when the nerve fiber gets stimulated. That release of acetylcholine then binds to postsynaptic receptors. And when those postsynaptic receptors are occupied, enough of them, it will continue the signal down the nerve fiber, ultimately to the end effector organ. If this happened to be acetylcholine at the end effector organ in the heart, for example, in the parasympathetic side, then the acetylcholine would cause the slowing of the heart rate in the heart. This is an instantaneous, very short, quick response that happens. So it happens when this causes a physiologic response immediately, but not long term. Why doesn't it happen long term? Because that acetylcholine binds on and off of those receptors and it gets recycled or reuptake back to use again. So this effect we see happens only for a split second, and the body turns it off in part by recycling the acetylcholine back again for the next nerve stimulation to happen. It can also turn that effect off by inactivating the acetylcholine that's left behind. And there's an enzyme there that does that called acetylcholinesterase. And so acetylcholinesterase breaks down acetylcholine. This can also be a concern for us. There's drugs that actually interfere with acetylcholinesterase. And if you did that, you would have excessive acetylcholine action at these receptors. And in fact, that's how nerve gases work, is they inactivate the acetylcholinesterase. And so that's a real concern for nerve gas poisoning. And we'll talk more about that later in the year. So while acetylcholine affects the receptors in the level of the ganglion, we don't usually innovate drugs there. The only drugs on the somatic nervous system that we innovate are the neuromuscular blockers, which we'll talk about in neurology a bit, but more in surgery and in critical care medicine and therapeutics later in the year. But where we do have most of our drug work on the parasympathetic side is at the end effector organ in the lower right-hand image here that's circled on the parasympathetic side at the end effector organ. We don't really give a lot of drugs that are muscarinic or agonists or acetylcholine stimulators because acetylcholine's everywhere and it's kind of hard to be precise about that. So there aren't a lot of agonists that we're going to use. Okay, a few, and we'll talk about them throughout the year, but not many. But it's more common that a lot of drugs we use have properties that are antimuscarinic. Sometimes beneficial, like we talked about with ipratropium and the level of the bronchioles to open up someone's airway. But more often, we have a lot of drugs that are antimuscarinic and affect lots of these receptors and cause lots of adverse effects that we don't want. A lot of the antihistamines are antimuscarinic. Some of the drugs we use in mental health and psychiatry are antimuscarinic. Many of the drugs we use in urology are antimuscarinic. Some of which for beneficial effect, and sometimes the side effects are problematic. So we'll come back and talk about this. But over time, as you get to know where these receptors are and what happens as an agonist or an antagonist, you'll be well placed to predict which drugs produce which kinds of effects. So when we stimulate either the sympathetic or the parasympathetic system, we usually will expect to see a particular response. And the transmission of nerve pulses ultimately release acetylcholine in the ganglionic levels and acetylcholine at the end of the parasympathetic side or norepinephrine at the end of the sympathetic side. But we've already talked about the differentiation on the parasympathetic side of the nicotinic versus the muscarinic receptors. And in clinical practice, most of the autonomic nervous system receptors that we're most concerned of on the parasympathetic side are the muscarinic receptors. So these muscarinic receptors typically we're going to talk about when we refer to an anticholinergic drug, for example, antimuscarinic drug, we're really talking about muscarinic receptors, not nicotinic receptors. That'll become more clear over time. So again, here's sort of a review of this graphic. And there's sort of a lot coming at you here with all of this discussion. But keep in mind, we're going to really focus on the lower center part of this graphic, all the adrenergic receptors on the sympathetic side and all of the muscarinic receptors on the parasympathetic side. And we're going to subset focus which fibers are going to the heart, which ones are going to the bronchioles, which ones are going to the blood vessels, other areas of the body.